Idelalisib was evaluated in a large single-arm phase 2 trial, specifically looking at patients with indolent B-cell lymphomas. This included follicular lymphoma, small lymphocytic lymphoma, Waldenström's and marginal zone. This trial required patients to be exquisitely high risk. They had to have disease that was refractory to both alkylating agents and rituximab, meaning less than a partial response or relapse within 6 months of receiving one of these agents. This was a single-arm trial, and all patients were dosed with idelalisib 150 milligrams POVID, and they continued this until either progressive disease, unacceptable toxicity, or at the discretion of the patient or treating physician to stop therapy. This was the first registrational trial for drugs in this class, and this showed a rapid time to response, a median of 1.9 months, an overall response rate in the follicular lymphoma cohort of 57% with 6% CRs, and a duration of response of 12.5 months. For the entire cohort, the median progression-free survival of the follicular patients was 11 months. Since that time, there have been 2 additional PI3 kinase inhibitors approved for follicular lymphoma. A second oral PI3 kinase inhibitor called duvelisib, this was from the Dynamo trial. A comparable patient population showed an overall response rate of 42%. A third one, an intravenous PI3K inhibitor, copanlisib, in a lower risk follicular lymphoma group, showed an overall response rate of 59%. This drug is given IV on days 1, 8, and 15 of a 4-week cycle. So let's turn a little bit about look a little bit about managing patients with PI3 kinase inhibitors, and they do have a unique side effect profile. As I mentioned before, there's probably an immunomodulatory component to these drugs, and it was found early on that patients who have not had any prior chemotherapy had evidence of transaminitis, and this was probably an inflammatory hepatitis. It improved with immunosuppression, prednisone, and holding the drug. We can still see that even in the third line and beyond setting on occasion. And in general, it's important to follow the guidelines associated with the elevation in transaminases. So typically, if there is up to 5 times upper limit of normal elevation in transaminases, patients can simply be observed, typically with weekly labs. If it's anywhere from about 5 to 20 times the upper limit of normal, we'll typically try to either hold the drug or reduce the dose to 100 milligrams of BID. The vast majority of patients can actually get through this early period, but it does require that early on, even for well patients with no adverse events, that we're monitoring their labs about every other week during the initial period. The other notable adverse event for idelalisib and really for the PI3 kinases in general is GI toxicity. There's an early diarrhea that is usually a little easier to manage, and nevertheless, you need patients to report this. And then there can be a late onset, more inflammatory diarrhea that comes on at about 6 months or so. And patients, it's important to really educate your patients to report their side effects and make sure your clinic team, including nursing, understands that when a patient calls after being on idelalisib or really any PI3 kinase inhibitor for a number of months, and now all of a sudden they're developing diarrhea, this needs to be investigated. There is a standard algorithm that's available for managing the diarrhea, but many patients, in fact, over half of the patients in the initial study, could actually get back on their dosing of idelalisib despite developing GI toxicity. So these are unique adverse events, but they can be managed, and there are readily available algorithms for adjusting the dosing or potentially temporary holds for these adverse events.